Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and the vaccine chapter representative for the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of March 15th. Globally, there are 120.5 million cases with 2.67 million deaths. In the United States, 29.5 million cases total with 536,406 deaths as of today, March 16th. Looking specifically to kids, the data from the AAP's weekly report, effective March 11th, shows 3.28 million pediatric cases, which is 13.2% of the total, and that comes out to 4,364 cases per 100,000 pediatric population. In Arizona specifically, our cumulative number of cases for birth through age 19 is 132,720, which is 16.0% of the total number of cases in Arizona. That comes out to 7,218 per 100,000 pediatric age range patients. The COVID-19 associated mortality, the death number, stands at 24, which is second only to Texas at 47. So those are the numbers. The positive news, of course, is that there are vaccines coming and vaccines out there, and yet more on the way. The negative news, of course, is the potential impact of the mutant variants which are out there. This week's questions are almost all focused on the vaccine, so let's kick into those right now, and I'll just take them in order. So, number one, if staff and providers are vaccinated, do they need to double mask, or is either an N95/KN95 or a surgical mask adequate? Well, if our staff and providers in the office or healthcare setting are completely vaccinated, i.e. At least 10 days or 14 days out from their second dose, if they're in a two-dose series, then they do not need to double mask unless they are in the middle of an aerosol generating procedure. In fact, just the surgical mask is probably adequate, more to demonstrate to our patients by virtue of wearing the mask that we can and do support mask wearing for all the others until everyone is appropriately vaccinated. The double masking, quite honestly, is aimed at the ability to have at least one mask fit more properly. That's where the CDC has come out in favor occasionally of double masking, a cloth over a paper mask. But here in the healthcare field, quite honestly, that the N95 plus a surgical mask was only to protect the N95's integrity from getting saturated with droplets, and to allow the N95 to provide longer term protection. Well, if one is vaccinated, that longer term protection is less significant. So that's a long answer to answering the question, which is I don't feel, based on the evidence, that one needs to double mask any further or even consider the N95 mask unless one is in the middle of an aerosol generating procedure with a patient who is known or strongly suspected to be infected with SARS-CoV-2. That would be obviously those of us who are participating in invasive procedures, bronchoscopy, endoscopy, etc., and so forth. Far more likely for those of us practicing in the community with primary care practices would be the known asthmatic or the patient receiving an aerosolized medication, either through a mask or an MDI or something like that. Certainly those, as they generate cough, could be considered a higher risk, not the highest risk, but a higher risk of aerosol generation. So in those specific circumstances, one may consider wearing the N95. Realistically, though, the vaccines are so very protective that the theoretic benefit of that is quite low. Which of the messenger RNA vaccines are okay for, or do our adolescents qualify for? Meaning 16 years of age and up for the Pfizer vaccine, 18 years and up for the Moderna. Johnson & Johnson's vaccine, newly licensed for emergency use authorization by the FDA, is 18 years and up. That's the single-shot adenovirus vectored vaccine. So if and or when we are able to, in terms of priority to immunize adolescents, then any and all would fit by those age criteria. My hope, and I may even go on a line here and predict, that by the time we get sufficient doses delivered to the various states in this country to immunize all the qualified adults, that we will have confirmed safety data for all the vaccines for pediatric age range and up. Certainly, Pfizer has now concluded its study of age 12 years through 18 years and is submitting that data to the FDA. Moderna is close. They are very close to getting the 3,000 study participants of 12 years of age and up, and hopefully that data will go to the FDA soon. Perhaps some of us, maybe many of us now know that Moderna also has opened up a trial of 6 months of age and up in the Phoenix area. And my hope is that that study will have robust recruitment and that we may even have data going to the FDA by late spring. If so, then the question is moot. However, to answer the question specifically, which 16 or 18-year-olds qualify for COVID vaccinations? Any and all. The presence or absence of comorbidities will not affect the priority of those adolescents. So the hope is that by the time it's available, everyone will get that. The questioner goes on to say that they have at least one diabetic teen family whose endocrinologist apparently recommended waiting for the Johnson & Johnson vaccine rather than doing the messenger RNA vaccine. There's no scientific rationale behind this recommendation. All 3 vaccines are now shown to be effective, certainly sufficiently effective to provide protection against severe disease, which a diabetic teenager would be at risk for. And I cannot think of any immunologic reason to have that altered recommendation either. So as soon as our adolescents are given the green light for vaccination, I would support the closest and soonest available vaccine is the one to go for. Somewhat related, are there any new recommendations for uses of the monoclonal antibodies for high-risk children of age 12 and up? And again, that's per CDC recommendations, age 12 with presence of comorbidities, which include the elevated BMI, presence of chronic respiratory issues, chronic health concerns, etc., and so forth. So that there are no new additions to those CDC recommendations, and keeping in mind, though, that the monoclonal antibodies are really directed for use in those who are either asymptomatic or only mildly symptomatic. Their highest utility, their highest efficacy is in preventing escalation to severe disease in those patients. Somebody who already has moderate COVID-19, which again, that's kind of a subjective term, but if we interpret that to mean considering need for oxygen, considering need for respiratory support, it's already potentially too late for the monoclonal antibodies to have proven benefit in those patients. All this actually may be moot because at least one of the monoclonal antibody products, the one by Eli Lilly, will no longer be released to Arizona by the Health and Human Services Department, because Arizona has as one of its 2 resistant variants the Cal 20C coming from Southern California, resistant variant against which the monoclonal antibodies do not work. So it may be that we're about to lose efficacy of the monoclonal antibody products, at least in Arizona, where our resistant variant mix suggests that they won't be all that efficacious. Okay, so what information do we need for the CDC to come out with guidelines about vaccinated people and what they can and cannot do? I imagine this question was submitted perhaps 1 to 2 weeks ago because indeed the CDC has come out with those recommendations. We I think have all seen those in the media. They're interesting. The clearest recommendation is that individuals who are fully vaccinated, by which 2 doses of a 2-dose series or 1 dose of the Johnson & Johnson, and at least 14 days out, so time for full immunoprotective response to develop. Those individuals in a small group indoor setting do not need to mask if they are with other fully vaccinated individuals. They even do not need to mask if they are with other individuals who are low risk for disease, which I imagine means children under age 10, healthy adults with no comorbidities, and I think you can all generate the list, absence of immunodeficiency, etc., and so forth. So those are out there. They're readily accessible on the cdc.gov web page. However, the recommendation against long-distance travel remains quite active. So all the grandparents who are just itching to go visit their families, their kids and grandkids who are now fully vaccinated can do so, but I suppose they probably need not to fly to do that. It's very, very interesting to interpret that. I imagine that we will see yet further recommendations from the CDC come out as more information is available regarding the risk to the fully vaccinated person. Who knows? Who knows? We'll have to wait and see. Okay, back to vaccine questions. We have a couple really good ones here. The Johnson & Johnson vaccine is an adenovirus vectored, or it's called a replication deficient adenovirus vectored spike protein vaccine. And that's been described, including by me, as a more traditional vaccine. I need to clarify that this is not the traditional vaccine such as exists in our primary vaccine series, right? The DTaPs, Tdaps, IPVs, none of those are vectored vaccines. Even the attenuated live virus vaccines, such as the varicella vaccines and the measles, mumps, rubella vaccines, are not vectored. That those are attenuated virus, which are made to be replication deficient, not non-pathologic. However, the comment about being more traditional has to do with other vaccine products against more unusual, what I call the infectious disease fascinomas. So several of the viral encephalitis vaccines have been experimented with vectoring. So too the Ebola virus vaccines, as well as with messenger RNA vaccine. However, the vector approach has been used increasingly successfully in gene or modified gene therapy for underlying immunodeficiencies and congenital diseases. Mostly with good success, although Johns Hopkins ran into a major issue as they were deploying an adenovirus 5 vectored vaccine in, unfortunately, patients with HIV/AIDS, and that vaccine's virus activated and caused morbidity and mortality among some of the vaccine recipients. So I guess I would say perhaps the better term is the science behind using a viral vector to provide exposure to the, in this case, spike protein has been tried and tested for a longer period of time than has the messenger RNA vaccines, although both are not existing in a vacuum. There is good science behind them. So there you go. Another question from the same asker. Oh boy, here we go. Good English, folks. Very importantly, in my last podcast, I stated that physicians' offices were likely to be the last to get vaccines. Why is that? So please, but please understand me that this was not I support this at all. I was just commenting on what I think is the distribution reality in Arizona, which is the numbers of doses we're getting are going to the large points of distribution, the pod sites. And that is a logistical issue, and that is decision making, I think, at certainly higher levels than mine. The questionnaire goes on with an incredibly well thought argument for using physicians' practices to do vaccine delivery. I agree 110%. Absolutely. We are all very familiar with giving vaccines and doing so in a safe and high flow setting. In fact, many of these practices, I imagine many of the listeners, have experience with drive-through vaccine clinics just in the last year as we try to get our socially distanced families through to maintain routine vaccinations. So too, practices in Arizona stepped up in 2009 for the H1N1 vaccine, and once they were able to get vaccine delivered to their practices, were able to do a robust job of vaccinating the general population. So I fully agree that, to my mind, the most likely and the most sustainable way of vaccinating and retaining vaccination, especially booster vaccination, in the COVID-19 pandemic is through physicians' offices. Absolutely. That is not the current reality in Arizona. The current reality is to send a majority of the doses to the large distribution centers, which are largely staffed either by the state or by individual organizations with volunteer support. Fantastic, wonderful, they're great. I volunteered extensively at one of those, and it's a wonderful setup. But it is not sustainable for the next several years. Another part of the vaccine deliveries have gone to pharmacies, which is another point of distribution approach, and that also makes sense. But I would fully support our efforts to increase delivery to physicians' practices. And I suspect, and this was the reason behind my comment, my suspicion is that as we move into a maintenance phase of the pandemic, that we will morph into physician practices as the sites of vaccine delivery. It is not going to happen tomorrow. I do hope and anticipate that it could and should happen sometime in the next several months. There we go. Let's see, other questions. Why is the CDC considering lowering the social distancing length to 3 feet? I wish I had insight into the thought processes of the CDC, and given the large amount of research out there, I suppose I could see an argument for and against that. For lowering the social distancing length to 3 feet, because, and assuming that most people continue to wear a mask. Okay, well, that's certainly what we're doing right now, but not everybody. And there are obviously major parts of the country, including parts of Arizona, that are eschewing mask mandates. And so that's going to go away, or has already gone away. There's been no change in the aerosol or the droplet generation of a SARS-CoV-2 infected person. That certainly is 3 meters, or the equivalent of 6 feet or so. That has not changed either. So it may be that there's some thought about a lower viral load being expressed as people continue to get vaccinated and as more people get infected, and the overall viral expression in the community trends lower. But I don't know the why behind that. Certainly, for the reasons I've just mentioned, there's a lot of evidence which would suggest it's a bad idea until we can acquire or achieve herd immunity, which is still a target of 70 to 75%, depending on which model you follow. We've got a long ways to go before we reach that. So I don't have insight into that, and believe me, if I did, I would share it with you. Well, what else do we have? Do I think there may be a late spring influenza as the Arizona school kids return to in-person classroom attendance? Possibly, maybe, although the attendance is still supposed to be with social distancing and mask wearing. And it is likely the impact of both of those measures, masks and social hygiene, as the general term, which is supporting the absence of a flu season this year, thank heavens, and even the absence of an RSV season, and not so many rhinoviruses or adenoviruses or other respiratory viruses. So I do not imagine that those factors are going to change significantly, as most school districts are very transparent about mandating masks in the classroom, in the hallways, and hopefully have plans to enforce those during the school day, during the school week. Now, that said, I suppose we also need to wait and see what's going to happen epidemiologically. We're having sort of a late-ish winter. It's a little bit cooler. It sort of rained/sleeted in my house early this morning. But, we'll see what that actually means in terms of expression of respiratory pathogens in the nasopharynx as we start to hit the hot season. And I think this is the last question. Do I anticipate the United States seeing another resurgence similar to Europe? To be brutally frank and honest, I'm afraid the answer is yes. In fact, that is already being called for or noted by Dr. Fauci in relation to spring break. As much as college campuses are trying to limit spring break and keep their college students in safe settings, but yet there are still going to be, certainly from the K through 12 schools, there's currently is a spring break. So there may well be, from Travel Association, another surge of the disease. That, though, I think is going to be a lower impact on a third or a fourth surge, depending on what part of the country we're talking about, than the emergence of the resistant viral variants. That to me is the bigger concern. So far, we're looking at 4 major variants in the United States. Those are the United Kingdom's B117, the South African B1351, the Brazilian P1, and the Southern California Cal20C. In Arizona, we have confirmed presence of the B117 from UK and the Cal20C. And in Southern California, it has been reported that those two viruses underwent an antigenic shifting event in which they combined various parts to create a super mutant, which is highly contagious and highly virulent. In fact, there's now confirmed evidence from the United Kingdom that the B117 is 30 to 100% more fatal, higher mortality compared to the previously existing isolates which were in that part of the world. And that's while controlling for increased contagiousness, increased infectivity. So independently, that virus is already nastier. So if and or when the resistant variants gain a toehold in this country, and all four are in the United States, and if we are slower in our vaccine delivery, then we will have a significant population at risk for those viruses. And again, once they gain a toehold, it's kind of like pouring gasoline on a fire. The contagiousness is so robust that we will have local mini outbreaks followed by larger outbreaks. So all of that is not doomsday prophesying. It is simply recognizing the reality of what we're facing in this country. And so I do anticipate ongoing surges. The hope is, and one of the models looking to the future, is that those surges will be minor, will be small, will be shallow if you look at them on an epidemiologic time graph, and that we will be able to respond to those sufficiently with the medical resources that we have, i.e. hospital beds, ICU beds, ventilators, physicians, nurses, respiratory therapists, etc. and so forth. But the reality is very difficult to predict, obviously, because nobody knows what impact these variants have, other than the fact that they exist and they have the potential to be nasty. So there you go. Hopefully, actually, rather than ending on a challenging or a scary note, I do want to note that it is gratifying and rewarding and, in fact, hope-inspiring to see the energy coming out of the country, the federal response now in getting vaccines delivered to the states. The next job, as already discussed, is to get vaccine delivery sites to be everywhere so that there is no local physical time or any other barrier to an individual who wants a vaccine getting that vaccine. And in that I include pediatric vaccinations, since our only way through this pandemic is to vaccinate everyone, especially including the kids who will be the last holdout of potential vaccine transfer. So there you go. That I think is a positive note. I think that is achievable. I think we have a ways to go. And I think hopefully that we can certainly anticipate great results if we're able to support vaccine efforts at the level of our state. One last question, which I am just now as I review my list and I forgot to answer, and this one has to do with early MIS-C or the multi-system inflammatory syndrome in children. There are diagnostic criteria that they were established early on by the CDC, and they basically call for fever of 38 degrees Celsius or higher for at least 1 day, exposure to and or infection with SARS coronavirus 2, presence of several systems with disease, and then presence of several inflammatory markers which are elevated. So basically, one either does or does not meet those diagnostic criteria. Our local response, however, has been to create a list of the typical inflammatory labs that could be sent in a patient whom we clinically suspect MIS-C, and in including an EKG to look for any underlying cardiac or cardiovascular abnormalities, and chest radiograph to look for any associated respiratory disease, and then to make a decision based on the individual with 1 to several days of fever who's presenting with the possibility of MIS-C. Importantly, that the phenotype, the clinical appearance of our MIS-Cs recently has been more GI-based. In fact, the last several all came in as a possible suspected appendicitis or acute gastroenteritis, and instead, because we did the labs, were found to have extremely elevated inflammatory markers followed by evidence of cardiovascular disease, i.e. both right and left-sided cardiac dysfunction, and in some cases dysrhythmias. So I encourage you to pull up on the CDC website the diagnostic criteria. Another resource which is quite useful if one wants to create one's own diagnostic approach comes through is a task force statement through the American College of Rheumatology. And also, I'm happy to share with you what we've created locally. It's really based on the work of many others and making it into an accessible, easily followable protocol for evaluation of these patients. If so, please feel free to email me if that's easiest for you. Sean, SEAN, Elliott, ELLIOTT, at tmcaz.com. I'm happy to share with you what we have and also answer further questions. So with that, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, stay safe, stay sane, stay passionate. Hang in there, folks. Best wishes.